Yeah. So thanks, Catherine. Yeah, so as Catherine says, my name's Richard, and I'm one of the lecturers here at the University of Birmingham on the nursing degree. And as Catherine says, I'm also the admissions tutor as well for my SIN. So if there's any questions about what I'm going to be talking about today, that's fine. If you've got any more general questions about applying for nursing at University of Birmingham, I should be able to answer them as well. So feel free to ask away on either one if you haven't made it to one of our admissions talks today. So my background is basically in paediatrics. So I'm a children's nurse. I worked for quite a long time at Birmingham Children's Hospital, and my main clinical background there was paediatric intensive care. I've also done some general paediatric medicine and paediatric outpatients as well, and I've been in nurse education now for 10 plus years. So the session I'm going to do today is a bit of a cut down session that I deliver to my students, and it's all about really kind of assessing the health status of children and recognising a sick child, and how we recognise a sick child, so how we go about assessing what's going on with the child in terms of their health status, and whether they're ill or not and what to do about it. So because this is quite a short session we've got, it's very much a cut down version of the session I normally do. It's very much more long-winded session that I normally do. So I've just sort of picked elements out of it, but I can point out where I've kind of had to cut it down a little bit for you. So basically, as a nurse, you're very much involved in assessing people's health status. It's really important, when you come across a patient in whatever context. It might be in the community, it might be in a hospital setting, it might be in a GP practice. One of the first things you do, or one of the most fundamental things you do as a nurse, is to assess their health status. You have to know what's going on with them to know what sort of nursing input or therapeutic care that they need to help them with their illness or their condition or whatever. And in order to do a health assessment, there's a number of stages you have to go through. So the first thing you're going to do in any health assessment is you have to collect data, and that which kind of makes sense if you think about it. You can't make a decision on anything without accurate, up-to-date, good quality data, and that applies to pretty much anything across the board. And healthcare is no different. So the first time you're going to come across a patient in any sort of healthcare setting, whether it's a child or an adult, you need to collect data in order for you to make decisions about their health status. And there's various forms that you're going to use to collect the data. One of the most fundamental things you can do is just use your observation. Look at the child or the baby or the young person. You can tell an awful lot just by looking at somebody. You can tell a lot about someone's health status just by literally just looking at somebody. Are they overnourished or undernourished? Do they look quite pale? Is their skin intact? That sort of thing. Are they obviously breathless? Are they uncomfortable or in pain? You can tell all of those things quite often just by looking at them. So observation is absolutely key, and it's one of the fundamental things you have to have as a nurse, is very good observational skills. So part of your assessment and part of your data collection is going to involve observing the patient. The other key aspect is questioning the patient. So you're going to ask the patient questions, or the patient's family questions about their health status, about their medical history, about their own understanding of their health condition. And that's a really important way of gathering information as well. So the first time, as I say, you come across a patient in any clinical setting, you're going to go through a series of questions that find out information, about the patient and about their medical history. And that's also really important data that enables you to build your health assessment. And the other aspect you're going to do to collect data is you're going to measure things. So this involves doing the sort of observations on that you may be familiar with. So you may check someone's temperature, you might check their pulse, you might check their blood pressure, you're likely to weigh them, you're going to measure their height. So these sorts of measurements are also used as part of your data gathering that form part of your overall assessment. So to make your assessment, as I say, you need to gather data. So you're going to get that from observation, you're going to get that from questioning the child and their family as appropriate, and you're going to measure things as well. So in terms of like clinical observations. A lot of the time you have to make inferences as well. So sometimes it's not always obvious that data you've collected exactly what it means. And this can apply especially to children. Babies and very young children aren't necessarily very good at explaining what's going on with them, or telling you if they're in pain or if they're uncomfortable. So a lot of the time you have to use your inferences, and particularly as a children's nurse, you get very good at intuiting what's going on and interpreting signals and things like that from the baby or the young child. So that's the other thing you quite often have to do as well. And then the next and kind of final stage, if you like, is to make judgments and decisions based on the information you've collected. So you've collected all the data, you've made the appropriate inferences based on the data that you've collected, and then you can go on to make your clinical judgments about what it is that the patient needs in terms of their nursing input or their therapeutic input to help them either recover or to carry out activities that they're no longer able to carry out because of their illness or the fact they've been hospitalised or whatever as appropriate. So they're kind of the stages involved in kind of making a health assessment. And I've already hinted that with children, there can be some very specific challenges that don't always apply to other categories like adults, for instance. And some of those issues might be the sort of stage of development the child's at. So children obviously grow and develop in quite a sort of formulaic way, if you like. There's certain milestones that we'd expect children to reach at a certain time. Now, that doesn't apply to all children necessarily. All children vary to a certain extent, but there's certain milestones that we'd more or less expect most children to meet at certain times. So, for instance, you might expect a 6-month-old to be able to sit up unaided. By about 9 months, children start to crawl. By about 12 months, they start to walk unaided, and so on and so on. Now, as I say, every child's different, so you can't always rely on that, but they're the key milestones you'd expect most children to reach. So again, when you're assessing a child, it's important as a children's nurse that you have knowledge of what those milestones are, because it could be that if you, for instance, you have a 15-month-old child that's not walking yet, that might be a cause for concern. You have a 9-month-old child that's not sitting up unaided yet, for instance, again, that might be a cause for concern. So it's important that you understand child development. And obviously, the younger the child, the harder it is necessarily to, or the more inferences you have to make in order to get, accurate information. Communication can also be a problem, of course, and we'll look at this in a little bit more detail in a minute, but obviously babies can't communicate with you, they can't talk, nor can very young children. So before a child has sort of achieved a good working vocabulary, you can't normally get information out of the child themselves. So in those circumstances, it's generally speaking the parents or the family, whoever looks after the child, that you get most of your information out. So the communication aspect is a challenge as well. And the other big challenge in paediatrics and looking after children is there are a massive range of vital signs. Now, generally speaking, in kind of adults, we all exist in quite a narrow range. So our heart rates are all kind of maybe 50 to 80. We breathe maybe 12 to 18 breaths a minute, and it's all a fairly narrow range. With children, that's not the case at all. So very young babies, for instance, have a very high heart rate and a very high respiratory rate, so they breathe very fast, and they have very low blood pressures, for instance. And then as the child gets bigger and older, the values change to become more in line with what you'd expect as sort of more adult normal. So again, if you work with children, you have to have a knowledge of what all the different ranges are for all the different children. And we'll look at just a selected few of those in a couple of minutes. So they're kind of the extra challenges that you might expect or you'll come across when assessing children and looking after children as a children's nurse. So I've mentioned language there, so I just want to talk about this in a little bit more detail. So this is some of the typical kind of language development that takes place. So around 15 months is when children start to vocalise, and normally it's very much a jabbering type noise, and they play around with vocal sounds. So not really any recognisable words, but they play around with vocal sounds and jabber and mimic sort of speech patterns and things like that. And then at about 18 months, a child would normally be able to understand and use between about 6 and 20 odd words. And then once language takes hold, it absolutely explodes very, very quickly. So by 2 years, children can very often use around 50 plus recognisable words, and they will understand many more. And that's quite an important thing to bear in mind as well. So though children have quite a limited vocabulary in terms of what they can vocalise and use, the words they can use, children can actually understand a lot more words. So you have to be very careful, you know, what you say in front of a child. Don't assume just because a child only has a few words that they regularly use that they don't understand what you're saying, because children can understand speech a long time before they can confidently use it themselves. So that's a really important thing to remember. And also around about 2 years, children will start to use 2-word sentences, so start to join words together for the first time in terms of simple sentences, so maybe get down or pick up, that sort of thing. And then language basically just continues to explode after that as well. So by sort of 2.5 years, most children can have to use 200 plus recognisable words. But quite often you'll find there's very infantile construction. So although they're starting to talk in quite complex sentences now, you'll find some of the constructions can be quite infantile, even though they're perfectly logical. So a child may say they swimmed or they runned, you know, which if you think about it, makes perfect sense, but just unfortunately because the way our grammar works isn't correct. So that's a very, very common mistake for children to make at this age. And then by 3, children are starting to use personal pronouns correctly, so him and her and it. They're starting to use plurals appropriately, and also starting to use and understand prepositions as well. So these are the placing words. So they know the difference between on and at and under and things like that. And it's possible to have, a perfectly simple conversation with a 3-year-old child. That's not the problem at all. So. And then by 4 years, you're getting pretty much grammatically correct speech. And 4-year-olds can relate to recent events as well. So they can tell you what happened, you know, in the recent past. And they understand, you know, the difference between present and past and future and things like that. And another very common thing around this age, and this can be anything from sort of 2 to 3 to 4 really, is the constantly asking questions, and then particularly the why question. Very, very common in children of this age. And if you've anyone that has younger siblings or other children in the family of this age will be very familiar with this game, I'm sure. So the child will ask why about something. So you answer and tell them why. Then they say, and then based on what you said, they say, yeah, but why? So you answer that and they say, yeah, but why? And if you've got all day, it's a great game to play. But obviously it's just how the children learn about the world around them, constantly asking questions, why, when and how. Children will understand and happily listen to quite long, complex stories, and also enjoy jokes as well. So children of this age, around 4, have the verbal dexterity to understand that, you know, why something's a joke in terms of how it plays with language and things like that. And they'll likely know several nursery rhymes as well. So you can see how language starts, you know, at around sort of 15 to 18 months. And then once it starts, it absolutely explodes really, really quickly. So I mentioned about interviewing the patient in order to get information. So and obviously you have to take into account when you're working with children, you do have to take into account their developmental stage. So very young children, particularly under about 6, generally speaking, you're not going to get much useful information out of the child themselves. So in most instances, you're going to be addressing your questions to the parents or the family or whoever looks after the child. As you get beyond 6, you can evolve the child or the young person more in the process, and you like to get more sort of accurate, reliable information. But it's very much a judgment call, really. So there's no magic cutoff necessarily. So you have to use your judgment as whether a child is at an appropriate developmental stage to be fully involved in the process or not. But if you are, if it is a very young child and you're getting most of the information out of the parents or the family, that still gives you the opportunity to observe the child. And as I mentioned, observation can be key. You can tell an awful lot just by looking at a child. You know, as I say, are they undernourished or overnourished? Are they very pale? Is their skin intact? Are they stunted or whatever in terms of their growth? So observation is key as well. And also you can see how the child interacts with the family as well, and that can tell you lots of useful information as well. I already mentioned this point that you do need to bear in mind that children can understand a lot more than they can actually vocalise themselves. So if you're dealing with a young child with quite a limited vocabulary because of their developmental stage, don't assume they can't understand what you're saying. So, you need to be mindful of that if you're having conversations in front of the child. Don't assume they can't understand it just because of their limited vocabulary. Play can be also a very useful and powerful technique as well, particularly for getting information out to children, or if you have to explain things to children as well. If you have to explain to a child about an operation, for instance, that they're about to undergo, then doing it with using play techniques and dolls and teddies can be immensely powerful. And also, just if you have to take a child's temperature, you can take it on the doll first or their teddy first, and that's quite a reassuring thing to do to a child as well. So using play techniques is quite a very, very powerful aspect as well. Looking at it from the other point of view, sometimes it's better sometimes you have to be aware of privacy issues as well. So in the case of teenagers, for instance, you may be asking lots of personal questions that is not appropriate to ask in front of their parents or their family. So in that instance, it's kind of the other side of the coin, and you may want to exclude the family from those conversations, to give a certain amount of privacy and things like that. And as I say, as overall, you can observe lots of family interactions as well as part of your overall kind of assessment interview. So that's the interview side of it. And I mentioned observations as well and measuring things. So physical examination can be, again, a very powerful way of giving an overall indication of health status, for assessing growth and development, for looking at the significance of clinical symbols, and also to response to treatment as well. So I've talked about assessment as kind of the start of the process, but it's woven throughout the whole process. So as I say, when you very first meet a patient, you're going to use observation and measurement and interview to get information about the patient, and that's what you use to decide the therapeutic input that the patient needs. But once you start providing that therapeutic input, you need to assess whether it's been successful or not. So assessment is woven throughout the whole process. So you may, the patient may receive some nursing input, and then you need to know, well, has that been successful or not? If it has, then that might be the end of the matter. If it's not, then you need to look at why it's not been successful. Was the intervention not appropriate? Did the patient not respond in the way you imagined? Has the patient's health deteriorated in another way that prevented them responding to the treatment? So assessment is actually woven throughout the whole process. So all the things I mentioned before in terms of observation and measurement, yes, that is used at the start of the process, but also during the process and critically at the end of the process to know whether the patient or the child has responded to the treatment as well. That's really important as well. So in terms of how we do carry out a physical examination, there's 4 basic techniques which are commonly used, and these are inspection, palpation, percussion, and auscultation. And some of these may involve instruments, and some of us basically, you can do in the bedside just as you are. So looking at all these individually, inspection is really everything I've been talking about already, just looking at the patient. And as I say, that's very powerful. You can tell an awful lot just by looking at the patient. But it's not just sight. You can use other senses as well. So sometimes smell can be an important thing. Hearing can be an important thing as well. So things like a patient's urine output, for instance, and as nurses, we're obsessed with wee and poo and snot, by the way. So a patient's urine output, it should be quite clear, coloured, and not smell. If it's dark or blood stained or smells offensive, then that's a potential cause for concern. So inspection, can involve all of your senses, not just looking necessarily. Other senses like hearing and smell as well can come into play as well. Now, if you are examining the patient, then there's certain things you need to look at or think about. So the position of the patient can be quite key. If the patient's, hunched up into a ball, whatever, then that's not very easy to examine them. So you may have to reposition the patient to examine them. You need good lighting. It's no good trying to examine a patient, in the dark, whatever. So lighting can be quite important, and adequate lighting. And sometimes you have to expose the patient as well in order to inspect them properly and examine them properly. So clearly there you have to think about things like dignity and privacy. That's quite important as well. So Palpation really, it just means touching. It's just a slightly posh way of saying touching, really. And you can tell an awful lot just by laying your hands on a patient and touching them. So if a patient has a very localized pain, for instance, you can determine exactly where it is and the extent of it just by gently palpating over the painful area. And then the patient can hopefully tell you whether it's painful or not. And you may have like a fluid build-up, for instance, which can happen sometimes. And again, you can determine the extent and the position of the fluid build-up just by palpating or laying your hands on it and palpating it and feeling it and touching it. The patient or the child may have a very localized swelling, and again, that might be possible to tell and determine by palpating or touching it. And quite often those, if you have got a swelling, you can have a localized warm area. So again, you can tell that just by laying your hands on the patient and feeling for areas of warmth and things like that. So palpation, basically laying your hands on that, can be a really powerful technique as well. Now, percussion in this instance doesn't mean like drums, obviously, but you can see I just did a Google image search there and a drum came up, so I thought, yeah, that'll do. Percussion in this sense is very slightly different, and it basically involves tapping with very short, sharp strokes, and you can determine quite a few things with this as well. So if you want to try this at home, take your one finger of your non-dominant hand, it could be your first finger or your next finger long, that's absolutely fine, and place it over your sternum, which is the bony bit in your chest there. And then with your dominant hand, take another finger and tap in short, sharp strokes on your finger and listen to how it sounds. Now take that finger of the non-dominant hand and put it over your abdomen. And again, with your dominant hand, tap again. Now you may hear the slight difference in the sound. One's a lot duller and one's a lot more hollow. And that's because when you tap over the sternum, that's a solid bit. And when you tap over your abdomen, that's much less solid. So it sounds differently. So again, with percussion, you can use that to tell the position or the size or the density of air builds up or fluid builds up, that sort of thing. So again, percussion will be quite a powerful technique as well. And then finally, there's auscultation, which really means listening with a stethoscope, just a posh way of saying listening with a stethoscope. So you can use a stethoscope to listen to a number of things. You can listen to a child's lungs with a stethoscope. So if you put the stethoscope over their chest or their back or both, over where their lung fields are, you should hear the whoosh of the air going in and out of their lungs. And if you can't hear breath sounds going in and out, that will be a cause for concern. You can also listen to a patient's heart with a stethoscope. So you should hear the lub-dub of the heart noises. And again, sometimes you can detect issues with the heart from extra noises that you can hear. And also comes under this heading, though you probably wouldn't use a stethoscope for this, is listening to blood vessels. So as blood goes through the blood vessels, it is possible to detect the noise it makes. But this is normally by some sort of electronic machine called a Doppler. And so it's like an electric machine that you put over the blood vessels, and you can hear the whoosh, whoosh, whoosh of blood. So if you have concerns over the blood flow to limbs, for instance, for whatever reason, you can use that you can use Doppler machines to listen to the blood vessels as well. And that comes to this heading of auscultation as well. So they're kind of the 4 techniques you can use to assess a patient in terms of measuring things. So this is just some of the typical examples of things you can measure on a patient, and this isn't exhaustive necessarily, but I've just selected a few key ones here. So things we typically check on a patient when we're assessing their health status is check their temperature, take their pulse, do a respiratory assessment. So how fast are they breathing? How comfortable is their respiratory pattern? What's their air entry like when we listen to their chest? You can check their blood pressure. So that's normally done with like a blood pressure cuff you might have done at the GPs. So put a cuff around their arm, pump it up, and you can check a patient's blood pressure. Things like fluid and electrolyte balance. So how well hydrated are they? Are they overhydrated? Are they underhydrated? And things like their electrolytes, so your sodium and potassium levels, they all exist in a very narrow range. It's important that you keep an eye on those in a lot of cases. And also you can check a patient's neurological status. So how conscious are they? How awake are they? Are they drowsy, or are they completely unconscious, or are they alert and awake and orientated? So as I say, that's just a brief example. That's just, you know, not an exhaustive list, just an example of some of the things you can check. And obviously I can't go through all of those in this this session, so I'm just going to pick on a couple of them. So I'm going to talk about neurological status. But before I do that, I just want to talk about pulse, so assessing someone's pulse. So when we're checking someone's pulse, effectively we're checking someone's heart rate. That's really what we're doing, because the pulse is like a proxy measure for someone's heart rate. Now, you could check a person's heart rate by listening to their chest with a stethoscope, or sometimes you can put your hand over a patient's chest and you can feel their heart beating. But that's actually, you know, quite fiddly, quite awkward. It's actually easier to do by checking a pulse. So the pulse really is, as I say, is like a proxy measure for someone's heart rate. So when we take a pulse, we're actually assessing and counting someone's heart rate. And if you've got a background in biology, you'll know that your heart rate is set by your sinulatory node in the apex of your heart, and that's what sets your heart beating and sets the rhythm for your heart. And that's what we pick up on by the pulse. So normally there's a pulse for every time your heart beats. So your heart will beat in your chest, and that will send a rhythm wave down your vessels, and that's where you feel it when you check a pulse. So no, sometimes there may be a situation where you don't have a pulse for every heart rate, and we'll talk about what to do about that in just a minute. But basically, most people, you have a pulse for every heartbeat. So by checking your pulse, you're effectively checking your heart rate. Now, I mentioned at the start that children can have a very massive range of values in terms of what's normal for them. So again, here are just some typical values, and you know, you don't have to remember these necessarily, but this is just an idea of some of the range of values that different ages children can have. So I've already said, as adults, most adults' heart rates are around about sort of 60 to 80. Some people have a heart rate of around about 50. If you're particularly healthy and fit, it may be a little bit more, but quite a narrow range. But a very newborn baby, it wouldn't be unusual to have a pulse or a heart rate of up to like 160. That wouldn't be unusual at all. And then you can see there, as the baby grows and gets more towards a child and then a teenager and an adult, the heart rate gets lower and lower and lower until it gets to a more normal adult kind of range. So if you work with children and you look after children, often you have to be aware of what all these normal values are, and how, and you know, in terms of the size and the weight of the child. So when you're checking this on a child of a certain age and a certain weight, you have to think, well, is this normal for this age and size of the child? That's quite important. So in terms of measuring the pulse, generally speaking, we measure it at the radial artery. So that's, you can check this yourself at home. So if you just go underneath your thumb there, at the base of your thumb, just where your thumb meets your wrist, if you put your two fingers there, you should feel your pulse beating there. I can feel mine quite easily there. And normally you use the first two fingers. Not a good idea to use the thumb, because there's a pulse in all of your fingertips, a very slight one. In your thumb, it's a bit stronger. So if you use your thumb to check a pulse, it could be your pulse you're measuring, not the patient's. So ideally, use the first two fingers, put them over your pulse there, just under your thumb, and you should feel your pulse there. So, and then normally you'd count for 30 seconds or a minute. It just depends. It depends really. But what's important is you count for enough length of time to reassure yourself that it is a regular rhythm. So one of the things we do when we check a pulse, yes, we are counting it, so you know what the heart rate is, but also it's important that it's a regular rhythm. So going back to what I was saying about having a pulse for every heartbeat. So the pulse should be a regular boom, boom, boom rhythm. If it's irregular in any way, then that's a cause for concern. And it could be that the heart itself is irregular, or it could be the heart itself is fine. It's just that there's not a pulse for every heartbeat. Now, both of those can be problematic in their own way, so it's important to establish which. So one of the things when you check a pulse is not only are you counting it, but you also have to reassure yourself that it's a regular rhythm, which is why you count it for at least 30 seconds, preferably a minute. And the other thing it's important to check is that it's it should be, your pulse should be easily palpable. If it's really, really bounding, then that's problematic as well, because it could be that you've got very high blood pressure or something. And if it's quite hard to find what we call a thready pulse, that's a cause for concern as well, because it could be there's a problem with your heart, your cardiac output, or a problem with your peripheral perfusion. So it should be just easily palpable, but not too bounding, and not too thready. Now, you can check a pulse in other places. There's loads of other places you can check a pulse. So you can also do it just in the crook of your elbow there. So where your arm bends, if you just put your fingers down just in the crook of your elbow, just inside, there's a pulse there. That's called the brachial. There's one just in your neck there. That's called the carotid. There's one on your face there called the temporal. On the side of your head, there's one on your top of your cheek there, there's one in your groin called the femoral, there's one on the top of your foot, there's one on your ankle and on the back of your knee. So there are various places you can check a pulse. Generally speaking, for most of the time we go for radial, just because it's very convenient, it's easy to find, and you rarely have to undress a patient, etc., etc. So it's an easy, convenient one to go for. So there's sort of reasons that pulse might be elevated. It might be trauma or infection. So if the patient has a fever, particularly, one of the things that happens if you have a temperature is you put your pulse up, or it could be just the patient's very frightened or anxious or in pain. You know, all of those things can lead to an elevated heart rate. So it could be the patient's got the fluid overload, or as I say, they're in pain. So that's all the issues around pulse. Now, the other thing I want to talk about and discuss is neurological assessment. So this is basically determining how awake somebody is, whether they're fully conscious or a bit drowsy or completely unconscious. And this can be important if the person's had a head injury, or you suspect they've had a head injury, or if they've had brain surgery or something. Now, a lot of the time you can tell someone's neurological status just by looking at them or by interacting with them. If you talk to somebody and they know who they are and where they are, and you know why they're in hospital, if they're in hospital, and what day of the week it is, you can be reasonably assured, I think, that there's no major concerns over their neurological status. If they're a little bit drowsy, then that might be more a cause for concern. So a visual assessment is sometimes all that's needed, and you can tell from whether they're orientated or drowsy or irritable. Now, one technique that's used quite a lot and a very quick assessment is what's called the AVPU scale, and I'll talk about that in just a minute. Another slightly more detailed way of assessing someone's neurological status is the Glasgow Coma scale, which again I'll talk about in a minute, and also there's pupil response as well. So just taking AVPU to start with. AVPU stands for basically awake, responds to pain, responds to voice, responds to pain, and unresponsive. So this is like a 4-stage scale, if you like, for someone's conscious level. So if you approach somebody and they're fully awake and orientated, and as I say, they know who they are, where they are, what day of the week it is, that would score them an A on the AVPU scale. So there'll be no concerns there. If you approach somebody and they don't immediately open their eyes and start interacting with you, but then they respond to your voice, so you say their name if you know it or whatever, and they respond to your voice, and then they start interacting with you, that's kind of the next level down. So they may be a little bit drowsy or just slightly sleepy, but no major cause for concern. If you approach somebody and you speak to them and they still don't respond, then the next level is introducing a painful stimuli, which sounds dreadful, but it's one of those ways to determine how responsive somebody is. So there's various ways that you can do a painful stimuli. One of the ways is to squeeze your finger there, just where your nail is, squeeze either side of your nail on your finger, and if you squeeze hard enough, that's actually quite painful. Also, just at the top there where your eye socket is, if you follow your eye socket round to your nose, there's a knot, you feel a little notch there. If you squeeze there, again, that's actually quite a painful thing to do. You can rub your sternum quite briskly, and that's quite a painful thing to do as well. So it sounds like a dreadful thing to do, but sometimes it's necessary to find out the level of consciousness of a patient. So if I was to squeeze a patient's finger, I would expect them to pull their finger away from the painful response. If I was to squeeze a patient there, just in the eye socket, I'd expect their hand to come up and push my hand away. That's what you'd normally do if you were responsive. So if the patient has those sorts of responses to pain, it shows they have a reduced conscious level, but they're not completely unresponsive because they're able to respond to pain. So you'd still be quite concerned over a conscious level that was down at P. So they're very sleepy, but they are actually responding to pain, but they're not obviously responding to voice. So a slight cause for concern there. And then if the patient doesn't respond to pain at all, they're categorised as unresponsive. So that's the lowest level of response. And you'll be very concerned about a patient that was coming up as unresponsive, and it would need, you know, immediate therapy or whatever, or immediate input help. So that's AVPU. Slightly more detailed assessment, neurological assessment you can do is what's called the Glasgow Coma Scale, and this is based on 4 different measurements. It looks at eye opening, it looks at the patient's verbal response, and it looks at the patient's motor response. So a Glasgow Coma Scale you may do on a patient, as I say, one that's had a head injury or a suspected head injury, or one that's had neurosurgery or some sort of brain surgery where you have major concerns over their neurological status. And it's expressed as a score out of 15. So the minimum you can score is 3, and that will be very profoundly unconscious. And the maximum you can score is 15, and that would count as being fully awake and orientated. And as I say, it's 3 different aspects you measure. So the first thing you measure is the patient's eye opening. So if the patient's eyes are open spontaneously, that scores the maximum amount of marks. And then if the patient's eyes open in response to voice, that's the next level down. If they open in response to painful stimuli, that's the next level down again. And if the patient's eyes don't open at all, then you score minimum marks for that particular section. The verbal is basically the patient's ability to interact with you in a meaningful way. So if they're orientated, and as like I said before, if they know who they are and where they are and what day of the week it is, and they're able to verbalize things rationally, then that would be no concern. If they were less than coherent for vocalizing, then that would be more of a cause for concern. And again, it goes down until they're unable to vocalize completely. And then motor response. So you could ask the patient, you know, can you wiggle your fingers? Can you wiggle your toes? Can you squeeze my hand? And if they're able to respond appropriately, that would score 4 marks for motor response. And then it goes right down to responding to pain and then not responding at all. So as I say, each section is given a mark, and then the marks are totaled up, and it gives you a score out of 15 to determine your conscious level. So around about 15 would be fine. Around about 8, you'd be starting to get quite concerned about the patient's conscious level. Now, straight away, I imagine you can see a problem with this, trying to apply this to children. So a lot of this relies on the patient being able to understand what you're saying and respond. So if you said to a 6-month-old baby, you know, do you know who you are and where you are? Clearly, you're not going to get a very useful response out of them from that. If you ask them to squeeze your finger, again, you're not going to get a very meaningful response. So it is possible to use this with children, but it basically had to adapt it to look at what, you know, normal vocalizing and normal baby movements, so it can be a little bit subjective, so particularly if you've never met the child before. And then the final thing to look at from a neurological status point of view is pupil response. So this is where you shine a light in someone's eyes to see their pupil responding. So before you even start, you look at a patient's pupils, and most people's pupils are round, and they should be equal. And if not, that would be a cause for concern. And then you shine the light in each pupil, and the pupil should constrict quite briskly. So it should get very small and very briskly. If it's a sluggish response, or no response at all, that would be a major cause for concern. Or if the pupils were unequal, that would be a cause for concern. Now, a very useful thing about pupil response is you maintain it even if you're like anaesthetized. So you have a patient that's anaesthetized, unresponsive because if they've been anaesthetized, clearly you can't do any other sort of neurological assessment on them because they're not going to respond to you. That's the point of the anesthetic. But you will maintain your pupil response as like a reflex. So you can always look at pupil response on a patient, and that's another useful neurological assessment to do either on its own or in conjunction with the Glasgow Coma Scale as appropriate. So that's a very whistle-stop tour of just a few issues in patient assessment. Obviously, there's a lot more to it than that, but if anyone's got any questions, then I'm happy to take them.
Oh, God. Thank you, Richard. We do have a few questions. People are asking, how long are the lectures for, and are they recorded, and is it optional to attend lectures recorded?
Okay, so I mean, lectures vary really. I mean, they're anything from a couple of hours, hour up to a couple of hours. Most of us do record our lectures, yes, and we are encouraged to do that. And if they're not recorded at the time, then we generally provide